Well, good morning, everyone, and welcome to our second grand rounds of the academic year. It's my privilege to introduce, we have two speakers for a two-session series. The first session is today. The second session will be next month. And our two speakers are Dr. Yeager Alli, who's right here at my left, and Dr. Karen Yeager, who, if anybody can see, I don't know if you can see out in Zoom, but they will both be tag teaming this topic of QI for the next couple of months, which is useful for the residents because all of you are going to be starting QI projects as start of your for your what you call them, the continuity clinics, and then also for on the attending level, Dr. Yeager is involved with a lot of the QI projects that are for the PSQs. Yes, okay. And so there are a lot of things that she wishes that everybody understood. So hopefully by the end of these two sessions, we'll all be at a higher level with QI. So anyway, Dr. Yeager Alli is a board certified internal medicine and lifestyle medicine physician focused on advancing high value care, whole person care through quality improvement, education, and well-being. She's also a Lean Six Sigma Black Belt and has led award-winning quality improvement initiatives across multiple healthcare systems, integrating nutrition and lifestyle medicine into primary care and driving practice transformation. Throughout her career, she's maintained longitudinal patient care while leading clinical, academic, and systems level work. She's completed her residency at the University of Arizona College of Medicine, where she served as chief resident and founding medical director of the Phoenix VA Academic PAC Residency Clinic. She's also done leading award-winning QI work. She later served at Mayo Clinic, Arizona as assistant professor and faculty member of Mayo Clinic Quality Academy, and now contributes to as the American College of Physicians faculty focused on quality improvement education and physician peer coaching. She's also principal of wellness medicine and associate professor at Clayton University School of Medicine and chief wellness officer at the Seeds to Inspire Foundation. Her book, Towel and the Super Procedure Pals at the Grocery Store, reflects her broad quality improvement work, translating nutrition and lifestyle medicine into practical tools that support lasting behavioral change. And then Dr. Yeager, do you want me to introduce you now or just wait till the next month? Okay. Okay, so without anything else, I'm going to change the microphone settings because Dr. Yeager wants to use the handheld mic.
That one. No. I'll start thinking.
There's a handheld.
This is the.
Is it on
the lavalier
thing?
Thank you.
Well, it's got a handheld on
It
here.
does have handheld.
Okay, I'll turn it up. Try it.
Okay, is that any better?
Leave one of them on and we'll see.
Okay. Hi, everybody. Thanks for coming. You guys are great. So I was just introducing myself. So I'm Dr. Yeager Alli. I'm a dual board certified internal medicine and lifestyle medicine physician. I'm also the discipline steward of nutrition and lifestyle medicine at Clayton University School of Medicine here in Phoenix. And this is a passion project for me because of the fact that I've always integrated nutrition into my practice. In medical school, I had a really phenomenal professor who also showed us how simply we could do that. If restaurants like Taco Bell can make a multi-billion-dollar organization out of like 4 ingredients, we can do it too. So that was a really eye-opening point that I learned in medical school. So I taught all of my patients with that same lens, that we can use nutrition towards both disease prevention and treatment, and even in some cases reversal. So some disclaimers and disclosures. I received a grant through the American College of Physicians, which supported teaching clinicians about nutrition and lifestyle medicine towards chronic disease prevention and treatment. I received an NIH R13 conference grant that will support conference later this week. I'm faculty with ACP, and then I'm a board member of the American Medical Women's Association and the author of the book that we'll be talking as the point of the intervention. And of course, educational and informational purposes only, not to be construed as medical advice. So acknowledgements again, thank you so much, Dr. Karen Yeager, and the rest of this phenomenal faculty here. It's not every system that offers resources like this to you. And there's so much data to support that when you can do great quality improvement work, reduce burnout rate. I'll use the point.
Yeah.
Okay, no problem. That's okay. So the value of learning these skills and hearing it in different forums and having support for it through your system is a big deal. So, and I also want to just say thank you to all those involved in preparing this CME for us today. So who wants to go to Costa Rica? So because you are so lucky to be in this room with me today, I worked it out with Dr. Yeager that she will support each of you to go on a trip to Costa Rica. Just kidding. And there's only one caveat, which is that you must have backup for your clinical duties before Friday. So the trip is next week. And as long as you can arrange that, we can all go. Some of you are smiling, some of you look dismayed. For those who seem a little bit skeptical, what are some of the barriers that you perceive? What's the problem that you're identifying? And I'll ask you to speak up because this makes it more fun. So what's the biggest problem with this? Yes, please. Okay, I hear minimal to nil the chances of getting backup. Say more. What are reasons why backup would be hard to arrange on short notice like this?
People available.
Okay, not enough people available. Say more, please.
All working on shifts, so there might not be genuinely enough people off of shift to cover the days being covered.
Okay, wonderful. So bringing up the fact that there's too few people available, everybody's working their shifts, no one to arrange that backup. Can someone regale me with what does it look like to arrange backup? Like, what does it look like to arrange that process? Just a high level. Like, is there a computer system that you put that information into? Is that like person-to-person work? What does that look like?
Usually for us, it's like you put out a almost like email blast, who can cover this shift, can you cover it? Unless you use your sick days, which then you call out to the chiefs who then organize and coordinate using backup, but I don't think it would be possible in Costa Rica.
Okay, so I'm hearing some skeptics.
Scheduled backup system, right?
Oh, there is a scheduled backup system. Okay, say more about the scheduled backup system. What does it look like?
That's the calling out to the chiefs.
Got it. So it's email based to the chiefs.
You would call the chiefs. The email based is like, I have a wedding in 2 weeks. Can anyone cover my Saturday shift?
Okay.
And then you trade with someone individually.
Okay, so the process is based though essentially on like a report out system, and you'd have to have someone respond to that. Okay. And then tell me more, who would be involved? Who would be your stakeholders? Who would be people that you would reach out to in this process of trying to arrange your last minute notification to get to Costa Rica? Remember, your goal is to go to Costa Rica. Okay. So who would you reach out to? Who would be the people that you'd want to get involved? Okay, you're pointing at some key pivotal leaders that you need to slip a little. Who else would you reach out to?
Your close friends, if they're on vacation, maybe.
Okay, so peers, because you realize that they are pivotal to responding. So great. Who else would be stakeholders involved?
Chiefs, right?
Okay, chief residents. And again, it makes it easier if we define the problem, right? So the problem is that we need last minute backup. The analysis is that this is a process that's people dependent. So we need people to respond to us in order to get that coverage arranged in a timely manner. The analysis is that it's pretty hard to do that on short notice. And then, so what would be an ideal intervention based on that specific problem that you identified, which is a call out system that requires people to respond to you? What would you think would be the ideal intervention? Remember, this is Costa Rica, once lifetime, all expense, I didn't mention, all expense paid trip. That's food, hotel, flight. Come on, you're not going to pass this up. So what intervention are you going to use to be able to get that? Is anybody just going to pass at this point? Anybody? Okay, good. We're on the same page. So what intervention are you going to use in order to make that system work for you?
Incentivize the other people.
There we go, right? So we're going to use a little bit of incentives. What other incentives are you thinking? So we have money involved, maybe trade-off.
2 shifts.
2 shifts. Whoa, that's pretty good. What else might you do? Babysit their kids. So we have an incentive process as potential intervention, okay? You guys just did QI. That's quality improvement. And you probably think like that 100 times a day, if not more. And the unique part about quality improvement, by the way, I'm sorry, that was not a real trip offer, but don't be mad. The neat thing about thinking this way is that it affords you with a skill that you can then apply to optimize any system. And then you fault yourselves less. You blame yourself for poor patient outcomes less because you know you have the power to redesign the system. And that's the beauty of quality improvement. So we're going to be talking about this in the context of a specific project that I did with residents in St. Luke's in Pennsylvania. And the learning objectives are to identify system-level contributors to clinical performance gaps using structure, quality improvement thinking, to select quality improvement interventions that align with root causes of care variation, to recognize the influence of cognitive biases, including solution-first thinking on quality improvement decision-making. And that, again, is that we're often rewarded. Even in our personal statements, all of us say we want to help people, but how we help is really based on if we understand the problem. And even in your training, that is the whole basic foundation of everything you're learning, which is how we first diagnosed appropriately what's going on with this patient before we throw solutions like surgery or systemic antibiotics at the patient. It might just be they just need rest at home. So we want to make sure we're defining and diagnosing it accurately. And it's the same approach in quality improvement. So, and at the end, you'll hopefully, or all throughout really, you'll be hopefully borrowing some of this way of thinking towards your own individual projects so that when we meet again with Dr. Yeager in August, that we'll continue this discussion. And just by show of hands, how many of you are working actively on a project, or even if you completed one recently? Just curious. Okay, awesome. All right. So we'll hopefully be bringing that into the conversation. So when I was a chief resident, and I did a dedicated chief year in patient safety and quality improvement through the VA. It's a national program. They have about 100 plus participants at this stage, and it's interprofessional. And the idea is for a dedicated year, you can come up with a system level project that supports your institution. And I loved it. During that year, I actually came up with this application, the patient safety consult service, where it was a resident run intervention. And we met on Fridays. That's how much people enjoy doing this, Friday afternoons. And so we would meet for a dedicated hour. We had a longitudinal project over, I heard someone say, over 4 weeks. And during that time, we would identify a adverse event or near miss that happened. And then the residents would figure out what was the underlying cause of that. They would figure out the stakeholders involved, come with a aim statement, and then a solution that was system level. During the 4 years that I was running that program, we had over 130 system level interventions. It was glorious. People felt good. When I started in that role, people would avoid me and walk the other way in the hallway. When I was leaving, I would find people just sitting, waiting for me in my office. So that's culture change. People love quality improvement. So this is an example of the group that we work with. And some of our rules were just, general respect for others, focusing on systems, and processes, not individuals. So we're never blaming a person. Yes.
Call out something that she was
saying with the resident-led intervention, like how many of the like PCRs or near misses that you guys have like been involved with, or they do like a root cause analysis, and there's like some root cause finding of like trainee, like this is something I experienced in residency too. So it's not just y'all like trainee involvement, or like feeling like maybe there was like supervision, but they like that's like veiled kind of language that's often used, and then you feel like, well, how do you fix the system, right? But you guys are the ones doing the work, which is like, so you are more aware of what the problems and what the gaps are that maybe people that are more removed from the process may not know. So I think that's why stuff like you and like learners and residents and fellows being really involved in QI is like so powerful.
I agree with that. And it does offer a lot of career opportunities as well. So, and then just asking why questions until you can no longer ask why, you felt you've exhausted the underlying cause. And then lastly, keeping that open mind. So we'll be doing that today. So here is the patient safety event that was submitted by a pediatrician. In this case, they said, I've had it, I feel so overwhelmed. I do my extensive nutrition counseling every single visit. It reflects that in much of my panel, though, our patients are still living and carrying excess weight, unhealthy weight. And I feel like it's me. It feels reflective on me, even though I know this is happening to other people, other clinicians, my colleagues. How can we better support our patients? And so this is a picture that was featured in an Australian Medical Association. And they show kids sitting in front of a screen that's featuring all the best foods in the world, right? And so all these ultra processed foods are constantly bombarding our children, right? And so we're identifying that as the American Pediatric Association or American Academy of Pediatrics identifies, that this is a broader structural context that our children are facing, and it's not a specific child-centric problem. However, in the last, this is the most recent pediatric update on obesity and the confounding factors that actually are causing this significant increase, with fourfold increase in obesity rates and prevalence since the 1970s for children and threefold for adults. And so they identified that the previous guidelines have always been more child-centric. Rarely do they acknowledge factors like all advertising systems or lack of food access or food equity. So these kind of considerations now inform the way that we counsel our patients. They have to be culturally sensitive, family-centered, and non-stigmatizing. So this was the concern that they brought up. And so we're defining our population. So we focused on K. Galgan, which is a women's shelter based in Bethlehem, Pennsylvania. They provide support to women who are pregnant at the time of intake. They also are facing housing instability, new mothers. They may have young children as well. They serve a bilingual population, English and Spanish speaking, and then often provide services up to the age of 2 years. There is also an opportunity for those who are considered non-core, which means that they are not formally enrolled in the program, but benefit from some of the resources through K. Galgan. So our example, and this is just a lovely story. This woman in this video, she had pursued resources through K. Galgan for her and her 4 children. At the time, she was pregnant with her 4th, and she ended up becoming a nurse. And so a lot of that she attributed not being able to, or being able to focus really truly on her children and her care plan. Of course, that doesn't happen with everybody. It's just the fact that when we have resources that are whole person centric, you have more opportunities. So this pilot study was flyer-based outreach. The participants in this program self-identified as wanting to learn more nutrition literacy. We had 20 families in total, 7 that came through their community outreach, 7 that were residential, and then of course that's 6 non-core, meaning they're not formally enrolled, but using the resources. So again, the definition of the problem we identified is that access is not the same as adoption. So in many of these populations, they may even have, in some cases, access to fruits and vegetables, just like many of us do. But the issue is that the barriers to how we see those foods and their nourishment of our body and disease prevention and even treatment and sometimes reversal is not made ubiquitous. So our aim statement was to achieve at least 80% family participation in a nutrition literacy program with a baseline of no existing program and in a shelter-based English and Spanish-speaking maternal child population while monitoring program feasibility as a balancing measure. And a balancing measure is basically an adverse event, or sorry, not adverse event, it's a medication side effect. So like if you're prescribing a medication and you have a side effect, you want to monitor for side effects. So it's the same thing with an intervention like this, where here's our intervention, how do we know it's working, but not creating unintended side effects. So that's the way to think of a balancing measure. And if you don't formally look for it, you won't know. So my question to all of you, so anytime you see a thumb, I would like it that we participate together. Think of it like you're texting on a group chat. And so you're telling me like, is this working for you? Is this not working for you? And then also it's an opportunity to hear more about what you're thinking. So despite years of nutrition counseling, many of you in residency probably experienced some of this as well, and attendings as well. Why do healthy eating recommendations often fail to translate into child dietary behaviors? What do you guys think? Yes, please.
A lot of times the challenge is fitting the healthy eating into the lifestyle of the family. So maybe they have a bunch of kids that all have to be at soccer practice and it's easier to fast food to feed them, or mom and dad or parents like work multiple jobs and don't have time to make dinner and like ordering out or the main thing that I've heard from parents.
Wonderful. Okay. And so she brought up a really excellent summary. She mentioned that time and alignment with our daily lifestyle makes it hard for a lot of people to prioritize healthy eating. And then you also mentioned food deserts. Can someone else talk about food deserts?
It's more like a social issue in general that people don't live within close enough access to actual healthy food, and sometimes the closest grocery store is like Circle K or a gas station that has not great options, opposed to like if you live in North Scottsdale and you're within a mile of a Whole Foods when you're at work.
Excellent. So his point is that many populations may not live close enough to a place where they can get healthy foods, particularly fruits and vegetables, beans and legumes, nuts, seeds, foods that would be nourishing the body. And so they don't have the ability to then sustain a healthy and active lifestyle. So excellent. You guys are doing great. So this is very much the reason. And so the other factor of why it's hard to translate is that if we don't have money, as someone's bringing up, and if we don't have systems that support how to integrate that into the process, that we can talk until everybody is literally blue in the face, but we have not done enough to make it easy to adopt into your daily household. How many of you feel like that? Because this is one of those factors that literally affects every single person in this room, where if we don't also have a schedule that makes it easy to cook for ourselves at home, to prioritize vegetables, fruits, beans, legumes, nuts, seeds, water, and all that good stuff, that it makes it really hard, even the best of us, even with access, right? Makes it really hard to bring that home. So we've defined the problem. The next is to measure the system. So we looked at this population of 20 participants, 20 women, and we surveyed them. And there was a significant prevalence of food insecurity, with 53% of participants describing feeling worried about running out of food. 65% reported food did not last or resources were limited. So we know that food insecurity is a confounding factor in this population. They also, at baseline, did not have nutrition literacy resources or a dedicated program, rather. And then limited objective child food consumption. We didn't have a measurement process to identify if the kids were eating fruits and vegetables at the time of this pilot. But we do know that the parents at least self-reported. And then outcomes, we'll be talking about that soon. But we looked at, we did a pre and post survey of their nutrition behaviors, and then we evaluated what they're eating by photos of their food plates. So analyzing further. So stakeholders, process maps, and fishbone diagrams. Have you guys heard of all these tools? Okay, we'll be talking about it, don't worry. So stakeholder analysis is exactly what you guys did at the beginning. We were talking about Costa Rica. There's a lot of motivation on that topic for whatever reason. And so stakeholders are anybody that touches the process. Literally think of it that way. Anybody that touches the process. And the best way to find out if there are additional stakeholders to consider is to ask your stakeholders, because they know who they go to for whatever additional process that's involved. Just like if you had an intern who's joining the team, they would go to their seniors to talk about, how do I do this? So intuitively, your stakeholders are key. Not only are your stakeholders important for knowing the process, but they're also key for getting stuff done. And so the more that you involve the stakeholders from the very beginning of the process, the more likely the process and the project and intervention are successful. So here are stakeholders. We have our families and children, our caregivers, staff leadership, the volunteers, community partners, and then the healthcare workers and clinicians. We identified their respective roles. As you can imagine, a lot of it has to do with workflow, getting communication out. In one case, we had community partners that were also identified as being able to supply the food to the families, local grocery stores, for example, that were excited to participate. And then we rated their anticipated engagement level. Why is it helpful to know how likely this person is to help you? Why, as an intern, would it be good to know who to go to for different respective needs that you have? I kind of led to that one, but what can you gather from that? Why is it important to consider this analysis of who's going to be most likely to engage? Wonderful. So I love it. A plan of attack is exactly the reason. So who do you want to spend more time with? People who are not going to help or people who are going to help? Exactly. So not only do you need to know who's going to be more likely to support your process, but for those who are not, you also need a strategy so they don't become obstructive. And so that can happen, unfortunately, but having a top-down and bottom-up approach where you're engaging as many people as possible in the process, having leadership to endorse your project publicly, meaning like your program directors, your social program directors, your quality improvement and patient safety leaders, that can also help to support the project momentum. And then, of course, meeting with the groups on a regular cadence. So the best time to meet is to have a dedicated time where they already meet. So not adding on an additional meeting, but asking for 5 or 10 minutes of their agenda to present. That really helps to move the project along. And that's what we did. And so those engagement strategies are really important. And again, the people who are less likely to come around usually do. Sometimes they're vetting the progress of your project first, but it's good to keep them in the loop and not to isolate them. Think of these people as maybe the ones who still have the Zach Morris cell phone from the 1980s. Is that a dated reference for too many in this room? Ooh. Okay, so, but like an old cell phone versus like a new cell phone. So the new cell phone people, you know, they're probably more likely excited about the project. The old cell phone people, don't isolate them, let them keep using their old cell phone, but keep them abreast that this new one is coming, okay? So, who has to be engaged for a child nutrition intervention to succeed? Who did I leave out? I may have left somebody out. Who did I leave out? Okay, I love that. You said schools. Who said that? Awesome. Okay, so schools, we'll talk about schools in a minute. The other factor is not just who did we leave out, but who often gets left out when you do interventions.
The kids or the person the intervention is directed toward.
Good, like the patient, the intervention-centric person. And why is that person important to include? You're on a roll.
I mean, if we're talking about this example, like adults can talk all day about how to get kids to eat something, but ultimately it's the kid that has to eat it. If anyone's ever had a toddler, that's really hard sometimes.
Okay, wonderful. So her point is that we often leave out the person who's receiving the intervention and that they often have the most important voice of why this would be or would not align with them. So really allowing them to have a voice and hearing from it is important. So we'll get back to that in a minute. Will you help me to remember schools and the voice of the child? Thank you. All right, so here's our current state map, which is a big fan favorite of Dr. Yeager. So as a chief medical informaticist, we know that it's super important that when we take data to Dr. Yeager, that we want not only for her to know that we really looked at the process from start to finish, but that we want to showcase that we've identified what the underlying cause is based on this review. So specifically, we start and end with a dedicated starting point and end point, and then we can fill in the gaps from there. The best people to do these, they call them Gemba walks, where you have somebody literally like a fly on a wall, observing what the start to finish process steps are, is your trusty medical student, because no one is more motivated to observe and to be part of a team than usually your medical student. So but they're just one of many. So all of you can also contribute. The other thing is that the different stakeholders that we talked about will all have a different vantage of what the process should look like from start to finish. So you really want to showcase this process map to all of your stakeholders at their various meetings to see if we left anything out. And so that's what we did. So our start is growth monitoring, nutrition screening, counseling, and our end is the follow-up and reassessment. So our stakeholders we talked about in the previous slide and the different process steps were growth monitoring. We talked about nutrition education referrals, nutrition resources and support, implementing the recommendations at home as the transition point from clinic to the home, where is most important. And then meals, childcare, school, someone brought up astutely, food exposure, like social media, billboards. Who's ever seen a billboard of broccoli? I've never. And then follow-up visits and so forth. So, and then the gaps we identify were based on those process steps, which is critical here. So do you remember I told you that when we start medical school, all of us want to do what? We want to help people. We can also dishelp people when we jump to the solution before we actually studied the cause. So identifying the process steps and actually looking at what the underlying gap is critical.
Can I say one more? So a lot of times when we are acting in a solutions oriented fashion, it's not out of like malicious intent or even not understanding the problem. Often when you're new to QI or really like passionate and engaged about the problem, you want to focus your interventions on things you can control, right? Because there is like an inherent like sometimes there's distrust of the system or like not having like knowing what the other. That's why the stakeholder chart is so important, because if you don't know how engaged your stakeholders are, then you may not like trust them to do their steps in the process, which might be much more powerful interventions. So I do see that a lot, and not specifically on the resident level, across all levels. Remember, like PSQs, I do projects with residents, fellows, and faculty, and one of the things that I often see is this well-intentioned desire to focus interventions on only things that you yourself can control, which will always give you an incomplete picture of the process.
Well said. So that again is the value of involving all your stakeholders in this discussion, and as opposed to we're doing this because I think it's right. So we want to look at what is weighted as the more likely problem. And so that was the other value of adding color coding. So reliability, meaning if multiple people were engaged in this process, how likely would the same outcome happen? If it's very variable or not reliable, then you'll see varied outcomes, which is what we see in nutrition education and its impact. So this is just a truncated version of the same process map. And so my question to you is, at which step in this process do you think we lose the greatest opportunity for change? And that's to the family, to the patient, to the child. It's one of the ones. What do you guys think? you can't be wrong in this. Just to give you perspective, this is kind of what Dr. Yeager was saying. It's just have we considered how it's weighted. So which of these factors do you think is most critical as we design our process intervention? Yes, please. Love it. So she was bringing up the one that has the most stuff to it. Very smart. So family context and daily environment. So the home, the school, childcare, and community. Perfect. Okay. You guys are right.
So cost of healthy food options.
I love it. And the cost of healthy food options. Very, very good point. So we'll talk about that in a minute as well. So this is our fish bone diagram. I love a good fish. So this is a really neat way of conceptualizing all those problems. And again, it's the whys. Pretend you're 3 and you literally just keep asking why until you've exhausted the process. And so here are different factors that many of you have already said as to why the effect is happening, which is persistent unhealthy weight gain despite evidence-based nutrition counseling. And so these are just different categories, and these categories can change, but they just help you to be more exhaustive and evaluating the different contributing factors. So we talk about people, which is not who's involved, but are they playing the right role, or do they have access to the right things? Sometimes there's overlap. Communication, equipment, environment, access, policies, and procedures. Often I'll add biases and heuristics as well, but I didn't in this particular case. But again, the same point is that the lack of a standard reinforcement process that supports the system at home allows for more variability in nutrition care delivery. So we need a solution that matches the problem, not Cheeto finger clips, but rather ways that support children and these darn billboards that are getting magnificent exposure to our children. On your way home today, do me a favor. Pay attention to how many of these billboards that you see in your daily commute, just from work to home. And I want you to consider that because for you, it's become so commonplace that you don't think twice about it. But for anybody who has a young child, including mine, who recently asked me, what's this, pointing to Sonic container at the playground, that is what they see and they're bombarded by. And the more you see something, the more normal it becomes. Remember, so on your way home, I want you just to humor me. Tell Karen when you see her in the hall, how many of those did you see on your way home, okay? So with that said, we created an impact effort grid to figure out which of our interventions do we think is going to be most effective. So highest impact, lowest effort is always the goal, right? No one likes to put in a lot of effort to get something poor out of it. And so all the things we said, not another nutrition handout, not another huge complex intervention without family engagement, not another costly high food access program and weekly follow-up appointments, but instead we chose high impact, low effort, which is a storytelling nutrition intervention. So low cost books, people love them. They're not expensive by most standards. Family, child are engaged, allow for repeated exposure to food concepts, and then standardized nutrition resources. So meet Teo. And Karen, if you don't mind to pass the book around, due to, I think ACGME rules, we can't send anybody home with them. But the good news is the book is available at the Emily Center and you can ask for it. It's also bilingual. So this book, I'm so proud of it. I have a laundry list of things I'm very proud of. Birth of my son, passing my boards, and then also this book. It reached #1 on a platform that will remain nameless. But all that said, I'm just very proud because it's been in the back of my mind since I was probably 5 years old. I've always thought it was neat and to be able to empower more people to think about food this way. My dad, who's a physician, banned sugar cereals around that time. So that's why I was pivotal at 5. And I had just figured out how to scoop the cinnamon toast crunch, I don't even know if that cereal still exists, from the milk. And so I was creating a sieve and I could drink that glorious, delicious, sweet mixture. And so then he banned it and I was like, what is going on? But it really truly became a healthy way of looking at food that informed my way of practice. It also was echoed when I was in medical school. I'm grateful for that. And then I had wonderful faculty in my training that allowed me to do shared medical appointments around food, around nutrition in my clinic. So that was pretty awesome. So this book It has a change concept, which is adding storytelling to the visit. It also allows for increasing exposure, building food familiarity, supporting behavioral adoption. And so we have recipes in the book. It's a child-led story, to the point that someone brought up earlier, which was great, is that often we're telling the story from what adults think kids should be doing. This is actually based and inspired on my son, who's very funny if you ever get to meet him. And it's basically what he does in the grocery store. And all the adults that I witness would support his journey around the grocery store and learning about food. And so having that lens allows children to then identify with the main character. So there's also activities, and I'll share more. But the question is, if the barrier is not only knowledge, but repeated exposure and engagement, what type of intervention would address the actual process gap? And that's why we chose the book. So again, here are the different activities of the book. And here's the call to action. So it says, pick a fruit, vegetable, whole grain like quinoa or beans, canned food, frozen, dried work too, and then check that they don't have added sugar or salt, and rinse the canned foods with water a few times. Crunch it or cook it with a trusted adult, and then draw the food that you're eating and the superpower it gives you. And so we use this intervention at launch over a 4-week program. We met with both a dedicated English cohort and Spanish-speaking cohort. We had a dedicated hour visit. We had these phenomenal pediatric residents. There were a total of 4 who participated. And for 1 hour, they broke the first half into reading 10 minutes of the book. The latter half was discussing with the participants about what barriers were to eating this way at home. And then the glorious thing of it all is the women, the moms at this meeting, then became support for one another. And that's critical here. So the first week was we read to them. The second week was they all had their own books to take home. And then the last week was post-intervention and getting feedback on the book. So here are the residents. Julia Burns, I want to give her dedicated acknowledgement. She was my counterpart for this at her residency since we were doing this afar. These are her other peers. We had the Kay Galgan staff who were really pivotal in getting fruits and vegetables into the mix. They even made a soup kit with fresh dried beans for the participants to take home. And then we had joining faculty was Dr. Jacobitz as well. So the control is that storytelling-based nutrition bilingual curriculum. Control meaning like, how do we sustain the intervention over the 4 weeks? So the storytelling-based nutrition curriculum was bilingual. We had dedicated cohorts for both. And then we had consistent 4-week delivery over 1 hour with the residents following a standard approach that was laid out, an agenda. Then we measured their engagement, nutrition measures of the caregivers, consumption patterns of the children by imaging. And then we had weekly barrier review with the parents, like what was working, what wasn't working, what do they want more support for? And then success indicators were high engagement, positive family experiences, reliable measurements, and then foundation for future improvement cycles based on that feedback. So we finished this project just at the beginning of the month, really. We were able to achieve more than 80% participation in this shelter-based program with both moms and children in attendance. Of the 20 families, more than half of the families participated in more than 3 sessions of the 4. So that's pretty amazing in terms of retention. And then meeting satisfaction was 5 out of 5. 100% of the material was rated as both culturally competent or culturally complete. So they felt like they could identify with the materials. And then the outcomes were that the child food patterns, which were demonstrated by the plate imaging, were significant and positive. And then lastly, the caregivers, I'll show you, did not show a significant change over the 4 weeks. We'll talk about why. And the balancing measure was that about half said that they did feel like they had lack of time, but we'll talk about how they dealt with that as well. So of the photographed meals, and we're still reviewing the final data, 98% contain plant-forward foods, 98%, which is pretty awesome. The other point is that the caregivers' dietary behaviors did not show much change. A lot of that was because for the way this was collected, self-reported data from the caregivers. The moms already had a pretty high baseline, which may or may not be accurate, but we'll know in a future iteration. The other consideration is probably more time to evaluate how that would help. But already they had pretty significant intake of fruits and vegetables as parents, but their children, they reported, did not. And then the other factor is just that we are able to get significant participation. So what does this teach us about the difference between providing recommendations and enabling behavior change? So it really does show that through a high barrier reduction format and a intervention that allows children to see themselves and to feel part of the discussion, that we can see feasibility in nutrition-centered interventions. The other thing that I wanted to point out was that having this forum for the women, for the moms, to talk about barrier reduction made all the difference. So specifically in this point about having too little time, even though they felt like that, they said they could either be putting the time at the beginning, which is spending the time to show the book to the kids, to go grocery shopping, let children lead the way, or they could be fighting them at the dinner table. So a lot of them shows that it's a lot more work to do that at the dinner table than it is to support reading to them and feeding them food that they make at home. So again, the mechanisms of change were family-centered, repeated exposure, accountability, and then spillover across the household. So I have some fun stories to share. Specifically, one of the parents said that she would send an orange home with her kiddo every day at lunch, and then that the kid would not have it in their lunch bag anymore. One week, though, the child had it back in their lunch, and she said, "Hey, you didn't want to eat this orange?" And her kid said, "Oh, well, the girl I give it to wasn't here today." Oranges, I was like, oranges, really? So then the mom, on her own, came up with a plan, which was to send 2 oranges with the kid, and then said, "You take one to your friend, and you eat one," and they did it. And she asked the teacher about it. So now, not only have we impacted her own child, not only have we impacted her friend who's eating the citrus, not getting scurvy, but we also have impacted the teacher. So we're making progress, and we are in some of these schools too. Another factor was grandmother would attend these meetings too, and she had diabetes. So she was making changes to her diet based on these interventions. And then another consideration was that one of the moms said, "I make the lunch for my husband. He's going to eat this now too." And that's what happened. So it was just neat to see how broadly this intervention was then expanding to others. So as we wrap up, my question for you is, what do you think you can do to integrate some of these approaches into your own QI projects? How does this stepwise process fit into your current approach? Who are your key faculty and staff that you want to collaborate with to make this happen? Those are your stakeholders or part of your stakeholder team. And then what are 2 things that you'll implement into this grant rounds? Okay, all at once. And then as you're thinking about that, I'm going to show you some fun pictures. So this was one of the schools that we're in, and the teacher, this is actually the librarian's idea. She put up all these individual pictures from the call to action, Teo's mission, and these are the foods that the kids said they're eating. This becomes a menu for them to be able to not only feel validated that they're eating real food that nourishes the body, but it also then helps if they're trying to figure out what to eat that day. So I thought that was so cute. These are some of the schools here locally in Phoenix that we've been able to participate in Roosevelt School District. And I wish you could have been there. I was reading to them. This in unison, they were reading with me. They had read it once before with their teacher that week. They were reading it with me to the point where I was a little discombobulated. But it was so glorious that they not only got excited about the concepts, but then when we brought them foods like dates and pomegranates and sunflower seeds and just a variety of different things, they were trying the food. We assessed for allergies first. That's so cute. And then thank you. And then here we have also, they have older kids teaching the younger kids as wellness ambassadors at their school. So they're showing pictures of foods that are nourishing to teach the younger kids. And we also have an activity guide that supports this whole process, but it was just so glorious to see that. So that's pretty much that. And yes, please go ahead. Oh,
I guess. Yeah.
Oh, yes, I'm sorry. Thanks. Do you guys want to share? Does anybody want to share? We have about 10, 15 minutes. I would love to hear what you're working on and how this is a good format. I just want to say one last thing. I felt like my QI work catapulted my career. And so even though it can feel very laborious to do this work on top of all the other things that you do, know that if you're doing this work and then you're telling people about it and you're presenting at conferences and you're sharing with your peers and it's making their workload lighter as well, that you're doing things right. And it's an opportunity to also get your name out. And that's not the only reason we do this work, but if you can get compensated for it in the future, if you can support patient care and you can expand to other places and other systems, then why not? So just an incentive to share. Go ahead.
Seen in some hospitals that like nursing versus physician QIs will be 100% siloed, totally parallel to one another. And I'm wondering your thoughts on, should these be integrated? Is it appropriate? Kind of that's just what I observed. It was interesting, like with some of the nursing QI stuff. Obviously, there would need to be stakeholder buy-in from physician teams or vice versa, but that crossover never happened culturally.
Okay, so that brilliant question was, should quality improvement work be siloed? What do you guys think? You can't say the wrong thing. I just want to hear your voices.
I don't think siloed, each are going to approach the same problem with perspectives and expertise. And I think if you also look at including as many stakeholders, including as many perspectives is always important.
Okay, so he said wonderfully that including expertise from a variety of stakeholders allows for greater what?
I would say greater coverage, different perspectives, and different approaches to solving the same problem.
Okay, he said different perspectives allows for greater coverage, different approaches, and different perspectives of solving the same problem. Do you guys agree? Yes, let's promote him. So that is incredibly important. And I agree with you that that happens in a variety of systems. I've worked in several, and there is a factor of that to some places. Some places do it better as well. The silo really slows down progress. The neat thing about quality improvement work, though, is it often brings people together. So even in a system where that's the culture, you have the ability to drive that in a different way. And yeah, that's been my experience time and time again.
I can speak on that locally. So, like all of you guys have you touch each of the divisions, but just so you know, kind of like the general institutional like QI engine that we talk about, like the PSQs, each division has to do currently 2 PSQ or projects, which are essentially QI projects. And next year that might change. But then there's also unit-based or service line-based, what's called QAPIs, which are nursing-driven projects. And historically, how many of y'all had, before I said that word, have ever heard of a QAPI? There's a few, they're the minority. So this, and actually that was something that I wasn't even aware of until I started doing PSQs and doing more QI work as an attending. So it was, and I've been here since 2013. So, so that is a local problem that we're actively trying to address, and how we're doing that is, like shout out to, I don't know if, Rick is on the call, Rick Engel, or Joanna Kramer, but like, as we work with the division leadership, the chiefs and the clinical champions on their PSQs, we're asking for more and more alignment with the QAPIs. And that is mostly run through like the high reliability units and things like that. So not every group will have a QAPI, but where they are working on it, we're trying to align the PSQs, which are a lot of times attending and faculty driven, with the nurse driven QAPIs around similar problems. An example of that is the ED, for example, is working on a PSQ on appropriate timing for antibiotics, like our bundle activation time for sepsis. And one of the big barriers we identified in previous years is that the hardest time to hit is fluid bolus within 60 minutes, because that's a short period and it's a lot in that first hour. There's a lot of nursing and tech interventions, right? Get access, get the patient on the monitor, get their vitals, send the labs, all of that stuff. So the bolus was the hardest piece. So then we made just the fluid administration within an hour, not the whole bundle activation, not the recognition of sepsis, not the disposition, just the fluid administration within an hour, the coffee goal. So that's an example of how we can align around different stakeholders working on different parts of the problem towards the same common goal. And we're going to be doing a lot more of that. And if there's any barriers or you're seeing siloed work, a lot of times, again, you guys are the ones that see it and not people doing the work. So let people know. If you see something, do something.
Wonderful. What are other projects? I'm curious about what you can just say by topic, even what you're interested in. It may not even be a project you've done. It might be scheduling time off, as came up earlier. What are your interests?
Community projects.
Is anybody interested in nutrition? Okay. We're actually working on a grant to support pediatric residents to participate in this kind of work. So it'd be time limited and high impact. If you're interested, let your attendings know. But what other things are you interested in? You can say, what really gets my goat? So what is that? What bothers you? What do you leave home or leave work thinking about?
Valley-wise 2 years ago, because we all do our own QI projects within our clinics and within our cohorts. We did QTB screening in children under the age of 2 and screening them for their risk factors and then increasing the screening for them.
Awesome. So QTB screening for children under age 3, so?
Age 2.
Age 2, wonderful. Okay, good job. And how'd it go?
Good.
Wonderful.
I was just one of the additional people on it. Shriti Patel was the main person on it.
That's still wonderful. Good work. How about others of you? What are you interested in working on? What are you passionate about?
We all have our projects that we're working on that are kind of QI based. So mine is med ed and improving our med ed education for residents and helping train them to be better teachers and medical educators. So that's my QI project for the year.
That's a big deal.
The chiefs do their own, or
Yeah.
the chiefs do one collectively?
We each do our own.
Your own. Okay.
Wonderful. Wonderful. Okay, how about on this side? I'll leave after one person on this side.
Interns haven't quite started their QI projects, but I'd say I'm interested in safety related things.
Okay, great. Okay. And you'll see things that, one other thing to point out is just that it can be easier when you're first starting off to identify things that seem off, but you're not yet sure if it's right or wrong. So like Karen said earlier, Dr. Yeager, if you see something, ask about it. That's a little bit easier to say it that way. Say, hey, is this what typically happens when we're doing this process? Is it supposed to look like this? And that way your attendings or seniors can give input. But it is really important because the risk is if we don't say something, a bad outcome happens, then that could mean somebody's life. So, all right, let's end on a happier note. How many of you, and I wanted to point out that one other benefit that came from this project was the residents who participated said it influenced their eating habits. So they are eating more vegetables and fruits as a result of talking about it. And I do the same. My patients, the people I consult with, they become my accountability buddies, whether they know it or not. So I can't talk about eating this way if I'm not doing it. So how many of you feel like that is something that you want to work on or something that you think is high importance, both either clinically or personally? Okay, awesome. Good for you. Make friends with people near you who didn't raise their hand. And then it is really important because we do know consistently the data is not going away. This is surefire way to live a long and healthy life. So, all right. This was great to work with you. Thank you so much for inviting me. If you have questions, you can email me or reach out on LinkedIn. Let me just get to that last page. And if you have questions, let me know. And then, yes, go ahead, please.
Just so they can use the.
Oh, yes, please. The evaluation. Great. Okay. Was this all right? Okay, awesome. Thank you so much. I appreciate you guys.
Joanna Kramer is great for like QI resources on the residency level. She's also doing a fellowship boot camp on QI, so that will build on the August 18th. So August 18th, come with your program, your project, and if you have any data, bring your data and your review. Dig into it a little bit more. And then also Rick Engel, the patient safety and quality group with Dr. Zorn and Kelleher, they all have everyone is now working together to align our efforts. So yeah, get them.